Hi everyone, and in this video I'll be discussing serotonin pharmacology and drugs used in the management of migraine. So basically when we think of autocoids, we discussed histamine in the previous video, and this video I'll be discussing serotonin. Serotonin is also called by another name 5-hydroxytryptamine, and whenever you think of carcinoid syndrome, serotonin excess comes to our mind. So other name for serotonin is also called as 5-hydroxytryptamine, and it acts on 7 different types of receptor. So in this video, let us start serotonin. Serotonin. So what is the other name for serotonin? It is also called by the name 5-hydroxytryptamine. So serotonin is also called by another name 5-hydroxytryptamine. So I can write it as 5-HT. Now this serotonin should act on the receptor. There are 5-HT 1 to 7 subtype of receptor. How many? 1 to 7. So in that, remember, all the receptors are G protein coupled receptor. All serotonin receptors are G protein coupled receptor. Exception is so let me write here, all are GPCR except the receptor called 5-HT3. Now this 5-HT3 is the ion channel receptor. So serotonin acts on 5 different subtypes, and all are GPCR except the 5-HT3, which is an ion channel receptor. Now moving on to the different type of receptor. So let me tell you, mainly we need to discuss 1 to 4, 5-HT1, 5-HT2, 5-HT3, 5-HT4. What are the drugs which stimulate or block them? That is a major thing what they will ask in the exams. So let me take the 5-HT1 receptor. In 5-HT1 receptor, number one, what we are going to discuss is a drug called 5-HT1A partial agonist. So these drugs are 5-HT1A partial agonist. Now what is the name of the drug which are 5-HT1A partial agonist? The name mainly you need to remember is buspirone. The name is buspirone. Remember, they all end with pirone. Similarly, we have a drug called gpirone. Then we have a drug called ipsapirone. The name is ipsapirone. So these are all ending with pirone. Now what do they do? What is their mechanism of action? Let me write here. Suppose this is the synapse. This is the synapse. Now this 5-HT1A is present here. So 5-HT1A is present presynaptically. What happens if you stimulate partially this? It decreases serotonin release. So it decreases the release of serotonin. So what happens if serotonin decreases? There is decrease in anxiety. So the drug will decrease the anxiety by what mechanism? By 5-HT1A partial agonism. Now where do you use these drugs? Particularly buspirone is the one which you have to keep in your mind. It is used for chronic anxiety. It is used for chronic anxiety or general anxiety disorder. So GAD means general anxiety disorder. Now, will this work in acute anxiety? No, because the drug takes at least 2 to 3 weeks to start working. So immediately it will not work. So if you give it in a patient who has acute anxiety and he has come to your hospital, it will not work. So it is only for chronic anxiety. Now, how better are they compared to benzodiazepine? We also use benzodiazepine in anxiety. How better they are? If I think of benzodiazepines, you know that they can produce tolerance, dependence, right? And they can produce sedation. So the advantage of these drugs are they will not produce no sedation, and they don't produce dependence, and they don't develop tolerance. So this is the advantage of this 5-HT1A partial agonist, that is buspirone. Many times you will confuse buspirone with bupropion. Remember snake, when you see the snake, you will get anxiety. So buspirone is for anxiety, bupropion is for smoking cessation. It's an atypical antidepressant. So try to differentiate them. Now, this is about the first category of drug, that is 5-HT1A partial agonist. They are buspirone, gpirone, and ipsapirone, used for chronic anxiety. And they don't work immediately. They take time up to 2 to 3 weeks to start working. Now the next group of drugs which are going to work on 5HT1A receptor, they are called as 5HT1B, 1D agonist. So the drugs are called as 5HT1B, 1D agonist. What are these drugs called as? Now they are nothing but triptans. The drug name is triptans. So can you tell me certain names of triptans? Sumatriptan. Sumatriptan can be given oral. So if you give it orally, the bioavailability is very less. So bioavailability is less. So many a times during attack of migraine, it is given subcutaneous, and also it is given as nasal route, that is intranasal. The name is sumatriptan, and all these drugs end with triptan. Then we have zolmitriptan. Zolmitriptan is also available as intranasal preparation. Then we have a triptan called frovatriptan. Frovatriptan, remember as forever. Frova means forever. Forever means longer acting. So the drug is long acting. Riza, so the name is called rizatriptan. So rizatriptan, remember as razor, fast. So it has fast onset. Riza, remember as the razor, faster. So it can cut faster, Riza. Then we have the triptan called elytriptan. Then naratriptan. Then almotriptan. Sir, so many drugs. Should I remember all these things? Please remember, they all end with triptan. That is the one thing you have to keep in your mind. And basically, you remember the drug sumatriptan. That's the most important drug you need to remember. So sumatriptan is the one which is given oral, subcutaneous as well as nasal. So these are called triptans. How do they work? What is the mechanism of action? So the mechanism of action is, what happens? They act on the receptor called 5HT1B, 1D. So they are 5HT1B and 1D agonists. What do? They cause vasoconstriction. They cause vasoconstriction. You know that in migraine there is vasodilation. So they cause vasoconstriction. Second, they decrease neurogenic inflammation. They decrease neurogenic inflammation. They decrease neurogenic inflammation. We all know that migraine is triggered because of the hyperactivation of trigeminal nerve. So when trigeminal nerve is activated, it releases inflammatory mediator, that is CGRP. So it decreases the activity of CGRP. What is CGRP? CGRP stands for calcitonin gene related peptide. Another important is the drug decreases nausea and vomiting. So this is the advantage. Now we know that in migraine there are two theories. One is vascular theory and neurogenic theory. Vascular theory tells that the reason for a headache is because of extracranial vasodilation. Neurogenic theory tells that there is trigeminal triggering, and that will release calcitonin gene related peptide that is responsible for headache. So it has both the advantages. Now where to use these triptans? Remember, triptans are the drug of choice for acute attack of migraine. So triptans are the drug of choice for acute attack of migraine headache. They are the acute attack of migraine. They are the drug of choice. Now, since they are vasoconstrictor, remember they are vasoconstrictor, they cannot be used in a patient with ischemic heart disease. So before giving it, rule out ischemic heart disease because they are vasoconstrictor. Already ischemia means the blood is not flowing and the coronary vessels can constrict further. Or patient having any coronary artery spasm, then also we should not use this drug. So it is not used in ischemic heart disease, coronary heart disease, even in pregnant, these are not used. Pregnancy, because it has shown to produce some fetal harm. So still if you want to use, there is a drug called sumatriptan that can be used, but still there is a risk. So pregnancy, it is contraindicated. Ischemic heart disease, coronary artery spasm, you should not use these triptans. Now, what is the drug interaction? Can we use with other drugs? Very, very important point. Suppose a patient is taking ergot. Ergots are also vasoconstrictor. Now, if you want to use sumatriptan, If you want to give sumatriptan or any triptan, they are also vasoconstrictor. So the question is, can we give them together to treat headache? Ergots and sumatriptan, can we use them together? No. You should not use them together. The combination is contraindicated. Why they are contraindicated? Because they both are vasoconstrictor. So if I want to use, how do I use it? If I want to use it, I have to give 24 hours gap. So patient is already on ergot and you want to give sumatriptan, don't give it immediately. You should give at least a gap of 24 hours. Now, another important point is triptans. When you are using triptans, you know that they stimulate serotonin. You should not combine with SSRIs, SNRIs. The reason is this will increase serotonin. This can increase serotonin and the patient will end up with a syndrome called serotonin syndrome. So the risk of serotonin syndrome increases. So please understand the drug interaction. Ergots and triptans should not be given together to a patient. Potential vasoconstriction. And triptans and SSRI, SNRI, there is a risk of serotonin syndrome. These are two drug interactions which is very, very important to be remembered. So we are done with 5HT1B, 1D agonist. They are called triptans and they all end with triptans. I told you the mechanism. They have advantage, not only vasoconstriction, they also cause decrease in neurogenic inflammation. And I told you the contraindication. So until now what I discussed is 5HT1A partial agonist, 5HT1B 1D agonist. And recently we have come up with a third drug and that is called 5HT1F agonist. The name is called 5HT1F agonist. What is the name? Can you guess it? It is called as lasmiditan. The name is lasmiditan. Now the advantage of lasmiditan is it will not produce vasoconstriction like triptans, but it decreases the CGRP. So the triggering factor for headache is trigeminal inflammation, and that will trigger increase in CGRP. So the drug decreases CGRP and it is used to treat acute attack of migraine. So it is used in the treatment of acute attack of migraine. You may ask a question, sir, we already have triptan, then what is the advantage of this? So you can use it in acute attack of migraine with cardiovascular risk patient. So patient has ISD or patient has coronary artery spasm or patient has uncontrolled hypertension. Then you cannot give triptans or ergots. Then you can use this because they don't produce vasoconstriction. They decrease the inflammation that is mediated through trigeminal inflammation. The name is called lasmiditan. So very, very important. So until now what I discussed is the 5HT1 agonist. Okay, so one is buspirone, second one is triptan, third one is lasmiditan. Now moving on to the next one. The next one is the receptor called 5HT2. Now most of the times 5HT2 we have antagonist only. So what are the drugs which are called as 5HT2 antagonist? Now the 5HT2 antagonist, they are nothing but they are also called as atypical antipsychotics. They are called as atypical antipsychotics. Can you give an example? So the name is called clozapine, then olanzapine. So we have clozapine, olanzapine and a drug by the name risperidone. So this is discussed in detail in antipsychotics. So they are used for treatment of psychosis. So that is number one, 5HT2 antagonist. Number two, we have a drug which is a 5HT2C, not an antagonist, it's an agonist. So we have a drug, it is called as 5HT2C agonist. Now the drug which is a 5HT2C agonist, the name is called lorcaserin. You read the name, lowers, L for lowers, O for obesity and serin, it's related to serotonin. So it's a 5HT2 agonist. It was used to treat obesity. It was used to treat obesity, but now it is not used. It is banned or withdrawn. The reason for withdrawal is it has shown to increase the cancer risk. So it has shown to increase the cancer risk. The drug is been withdrawn. It was used for obesity, but not now. So we have 5-HT2 antagonist, 5-HT2C agonist, that is called lorcaserin. Number 3, in 5-HT2, we have something called 5-HT2 antagonist and 5-HT1 agonist. So this symbol, what I am writing, is antagonist. The name of the drug is called flibanserin. The name is called flibanserin. Now, where do I use this? This drug is used in female hypoactive sexual desire disorder. So there is a condition called female hypoactive sexual desire disorder. That means decreased libido. So for that we use a drug. You read the name: F for female, LIB for libido, and serin for serotonergic drug. So it's a female libido enhancer, flibanserin. The name is flibanserin, so easy to remember. Flibanserin. Another drug is a 5-HT2 antagonist. The name is called cyproheptadine. So cyproheptadine has an antagonistic action. It's a 5-HT2 antagonist. It's a histamine antagonist. It's a muscarinic antagonist. So multiple antagonistic action of cyproheptadine. Now where do I use this cyproheptadine? Number 1, it is used to treat a syndrome called serotonin syndrome. Serotonin syndrome is a condition where serotonin is excess. So to manage that, we use the drug cyproheptadine. That is point number 1. Point number 2, whenever there is diarrhea in case of carcinoid syndrome, so there we can use it in carcinoid syndrome. In case of carcinoid syndrome. And also it is used off-label. Now what do you mean by off-label? Off-label means it's not FDA approved. So it has shown to increase appetite. The cyproheptadine has shown to increase appetite. So that is used off-labelly to gain weight in children. So it is used to gain weight in children. That is off-label, not a FDA approved use, cyproheptadine. So until now what I told you is 5-HT2. Number 1, the atypical antipsychotics. Number 2, I told you is the 5-HT2 agonist, a banned drug, lorcaserin. Then 5-HT2 antagonist and 5-HT1 agonist, flibanserin, female libido. Then cyproheptadine. So that is about 5-HT2. Moving on to the receptor called 5-HT3, and I told you the specialty is it's an ion channel receptor. I'll write it again. It's an ion channel receptor. 5-HT3. So we have an antagonist for that. Yes, you know these drugs. What are these? They all end with cetran, ondansetron. Okay, so ondansetron, granisetron, palonosetron, dolasetron, they are used mainly as the drug of choice for early CANV. That is chemotherapy-induced nausea and vomiting. So that is about 5-HT3 antagonist. One more 5-HT3 antagonist is called alosetron. So alosetron is used mainly in management of irritable bowel syndrome. So it is used in irritable bowel syndrome where the diarrhea is predominant. So diarrhea, predominant case, we use it, and we'll be discussing it again when we are discussing GIT. Now the next one is the 5-HT4. So 5-HT4, the drugs are agonists for that. What are the 5-HT4 agonists we have? The name is called cisapride and a drug called mosapride. The drug is called cisapride and mosapride. These drugs had prokinetic property, and we used to treat GERD, gastroesophageal reflux disorder, but these are banned because they increase cardiovascular deaths, and these drugs are banned. Similarly, there is a drug called tagacert. It is also used for constipation, and nowadays the drug is withdrawn. So it is also banned. So what is the only drug which we have 5-HT4 agonist? And that is called prucalopride. So prucalopride is a drug which is used to treat constipation. It's a drug used to treat constipation. So this is about the various serotonergic receptor, what are the agonist and antagonist. Generally speaking, 1 and 4 we have agonist, 2 and 3 we have antagonistic drug. So that is about the different serotonin drugs. So continuing with the other drugs which affect the serotonin receptor, we come across some drugs called ergots. So ergots are nothing but they are obtained from a fungus, and the fungus name is called Claviceps. It is called as Claviceps purpurae. And this fungus grows on the rye. So when the patient eat this particular rye, they have got gangrene. So it is also called as ergotism or Saint Anthony's fire. So that is a historical aspect. They are called ergots and they have action on serotonin. So the derivation is from a fungus and the fungus is called Claviceps purpurae. Right. So the mechanism of action of ergots, remember ergots have multiple actions like on the 5-HT. They have the action on alpha, they have the action on dopamine receptor. So in this receptor, some places it will act as agonist, some places partial agonist, some places an antagonist. So don't worry about that, right? So it has complex action. What has to be remembered is, what are the drugs in ergot? What are the things we need to keep in mind? Number one, during ergot discussion, the thing what we need to keep in our mind is ergotamine. So we have ergotamine, you add dihydro, it becomes dihydroergotamine. So dihydroergotamine. Now these drugs, they produce vasoconstriction and they have alpha blockade property. Now they are used mainly to treat acute attack of migraine. They are used to treat acute attack of migraine. Now you may ask a question, sir, are triptans better or ergots better for acute attack of migraine? Triptans are better because ergotamine, they only cause vasoconstriction, they don't decrease nausea vomiting, they don't decrease neurologic inflammation. You may ask you one more question that, sir, if they are alpha blocker, they should be vasodilating. Remember, the vasoconstrictor action takes the upper hand compared to alpha blocking property, so they are basically vasoconstrictors. Now, what are the adverse effects when you think of ergots? When you think of a mnemonic EFG. Whenever you think of ergot, remember this, ergots, F for fibrosis. They can produce fibrosis, and because they are vasoconstrictor, they can cause gangrene. The reason for vasoconstriction is, the reason for gangrene is because they are vasoconstrictor. So where they are contraindicated, similar to triptan, they are contraindicated in ischemic heart disease or any coronary artery spasm, or patient hypertension is not controlled, uncontrolled hypertension. So these conditions, we don't want to use it because the patient may have severe vasoconstriction. So they are called ergotamine and dihydroergotamine. They are used for acute attack of migraine. They are potent vasoconstrictor, and the main problem is fibrosis. Because of vasoconstriction, they can cause gangrene, and these are the contraindications of them. Now, if the patient has been given ergotamine and patient comes with gangrene symptoms. So before gangrene, the patient will have vasoconstriction symptom like numbness and tingling. How do you reverse this vasoconstriction? Before gangrene, we can reverse it. Now, the best drug which can reverse that is a vasodilator. So if there is vasoconstriction because of ergots, so let me write, when we use ergots, there is vasoconstriction, patient comes with tingling and numbness sensation. And then how do you reverse this? Give a vasodilator. Which is the best one? The best vasodilator that can be used is sodium nitroprusside. So the advantage of sodium nitroprusside is it's the equal dilator of artery and vein. So ergot-induced vasoconstriction, the drug of choice will be sodium nitroprusside. Now the second ergot drugs are ergometrin, and one more is called methyl ergometrin. It is called methyl ergometrin. So if you read the name, it has metrium, endometrium. So it is related to uterus. Now these drugs, the advantage is they have less vasoconstriction. They constrict but lesser chances, and they don't have alpha blocking property, no alpha blocking property. So that is the difference between ergotamine and ergometrin. And they are uterine stimulants. So they cause uterine stimulation, and they cause that sustained uterine contraction. So if I draw the uterus, see, this is the uterus and the baby is inside. Right. Now, actually, when during delivery, what happens? The lower segment should relax, upper segment should contract. So when we give ergometrin, the upper segment also constrict, lower segment also constrict. So this is the upper segment, lower segment. So the fetus is entrapped inside, and it will lead to fetal distress. That's the reason it is not used for induction of labor. Ergots are not used, particularly ergometrin and ergometrin, they are not used for induction of labor or in between labor. They are major use. Where to use them? Can you guess? They are used in postpartum hemorrhage. Once the baby is delivered, we want a sustained contraction, then only we use this ergometrin and methyl ergometrin. So the problem with them is uterine stimulant very good, but sustained uterine contraction without relaxation. Compared with oxytocin contracts the upper segment, relax the lower segment, and the contraction are intermittent. That's why it is used for induction of labor, not this. Now other drugs which are ergot derived, there is a substance called LSD. So it is called lysergic acid diethylamide. It is an hallucinogen. Number 2, we have a drug called methysergide, that is also ergot derived. So it is shown to produce 5-HT2 blockade property, and it was tried in migraine prophylaxis. So it is tried in migraine prophylaxis, but nowadays it's not used for that. Now the third group of drugs, you know them, they are nothing but bromocriptine and cabergoline. They are also ergot derived, right? So bromocriptine and cabergoline, and we'll discuss that extensively when we discuss endocrine pharmacology. So these are the ergot derived, ergometrin, methyl ergometrin, and then ergotamine, ergotamine. We go to the next important aspect, treatment of migraine. So the treatment aspect of migraine. Now please understand, migraine, it's very common in a female population, and it's a hemicranial headache, that is one-sided headache, followed by aura. Patient will have nausea and vomiting. Patient doesn't want to stay in the light, he wants to stay in the darkness, he doesn't want to listen to the sound. So that's a typical of migraine. So there are two theories proposed for migraine. I told you the vascular theory. So vascular theory is because of vasodilation of extracranial blood vessel. The neurogenic theory. So neurogenic is because of inflammation of the nerve, that is trigeminal, which will increase the release of calcitonin gene-related peptide. So these are the two triggering factors for migraine. But whenever you treat migraine, keep two things in the mind. Suppose a patient has acute attack, then what are the drugs you use? So patient comes with headache, sudden onset of headache, then what are the drugs we use? And what are the drugs we use for prophylaxis? These are the two things you have to keep in your mind when you think of pharmacotherapy of migraine. So let me take up and tell you first of all, what are the drugs for acute attack of migraine? Acute attack of migraine, what are the drugs? Number 1, so simple headaches can be managed with NSAIDs. For example, you can use diclofenac, or you can use aceclofenac. These drugs are NSAIDs that can be used. Many patients will have vomiting sensation, nausea, so better to give antiemetics. So antiemetics such as the ondansetron, metoclopramide, any of this can be given. So first is analgesic, NSAIDs, antiemetic drugs, ondansetron, metoclopramide, and you can also use triptans. So sumatriptan and triptans are the drug of choice for acute attack of migraine. Please mark this. Triptans are the drug of choice for acute attack of migraine. Apart from this, do we have anything else? Yes. We can also use ergots. I told you ergots, two types, ergotamine, and one more is dihydroergotamine. So it is called dihydroergotamine. Now, whenever using ergot and sumatriptan, you should not give them together. I told you there should be a gap of 24 hours gap. So there should be a gap between them, that is 24 hours. So apart from NSAIDs, triptans, antiemetic ergots, so the other drugs used for acute attack of migraine, apart from this, we have recent drugs. They are called as CGRP antagonist. So these are CGRP antagonist. In that we have two drugs, and they end with the name Gpant. So we have a drug by the name Gpant, and one more drug is called Gpant. So you read the name G, emergency pant. So CGRP antagonist. Another drug recently approved is 1F agonist. What is the name of it? Yes, it is called as lasmiditan. So CGRP antagonist, they end with Gpant, and 1F agonist is called lasmiditan. So these are the drugs what we use for acute attack of migraine. The drug of choice is triptans, and other drugs are ergot, NSAIDs, antiemetics, CGRP antagonist, and 1F agonist. Now, can you tell me what is the advantage of lasmiditan? You can use it in a patient with cardiovascular risk factor. Now, moving on to the drugs used in migraine, which are used for prophylaxis. Prophylaxis. Why do we give prophylaxis? Because we don't want the patient to get acute attack of migraine. Because once the patient gets a migraine attack, it's like debilitating, and patient will lose that day. He cannot go out. He cannot do any work. So that's the reason we don't want the patient to get the attack again and again. So we use drugs which prevent that. The mnemonic for that is 2ABC drugs. So the mnemonic is 2ABC. So what is that? T for? So T for the tricyclic antidepressant, and the name of that is amitriptyline. So the name is called amitriptyline. O for a toxin, and you all know that toxin, it is called Ona botulinum toxin A. Then we have A. What is that? A stands for? A stands for the anti-epileptics. So we also use anti-epileptic drugs for the management of migraine prophylaxis. You can remember by the mnemonic GST drugs. So what are these GST drugs? The name is gabapentin, and S for sodium valproate, and T for a drug, it is called topiramate. So the GST drugs are gabapentin, sodium valproate, and T for topiramate. Now coming to the B, the letter B, they are called beta blockers. So in beta blockers, the most commonly used drug for prophylaxis is propranolol. So propranolol is one of the most commonly used drug in prophylaxis of migraine. The other drugs are timolol can be used. Metoprolol is also being used. But among all the drugs, the most commonly used drug is propranolol. That's the one. Now the reason why beta blockers are used is, you know that anxiety will increase the trigger. It will trigger the migraine, so it decreases anxiety, it causes sedation. And also these beta blockers, you know that they are vasoconstrictors. Then the C stands for an ARB, that is called candesartan, that can be used. Then we have calcium channel blockers. There are two types, T-type calcium channel blocker and L-type calcium channel blocker. The T-type calcium channel blocker, any guesses? The name is called flunarizine. The name is flunarizine. And L-type is called verapamil. So you may ask a question, sir, if I use verapamil, they are vasodilator, right? Now, please understand the triggering factor for migraine is vasoconstriction followed by vasodilation. So the triggering is vasoconstriction. So this drug will not allow the trigger to occur. It will dilate and prevent the triggering. But during acute attack of migraine, we never use verapamil because it's a vasodilator, neither flunarizine. That's why they are used for prophylaxis. The basic use of propranolol, I told you, is they decrease the anxiety, they cause sedation. That is the reason why they are used as prophylactic. One more C is CGRP antagonist. CGRP antagonist. So what are the drugs which are called as the CGRP antagonist? So let me take one more slide and tell you this. CGRP antagonist. So the name is erenumab, galcanezumab, then fremanezumab. So this is the recently approved drug for prophylaxis. So erenumab, galcanezumab, and fremanezumab. So recently we have come up with eptinezumab. So basically I can give a clue for this if you don't want to remember. They all end with nezumabs. Nezumabs. Except erenumab. So all other drugs end with nezumab. And there is one more clue for you. Every girl can free a man. So erenumab, girl can free a man from what? Headache. But if she free a man, she will become empty. He will become empty. So eptinezumab. Epti means empty. It sounds like that. So every girl can free a man. So if a man is free, he will become empty. Eptinezumab. So these are the CGRP antagonists. Sir, you also told there is gepants like ubrogepant and rimegepant. So these are also used. What's the difference then? Remember, these CGRP antagonists are for acute attack of migraine, and these are for prophylaxis. So they are given as monthly injections as prophylaxis. So that's the difference you have to find out in your exam. Don't confuse this. That's why I told you G for emergency. Remember it for emergency attack. MABs are for prophylaxis. Then you will not have a confusion at all. So with that, we have done with serotonin pharmacology. I explained to you what the drugs are: 5-HT1 agonist, 5-HT2, then 5-HT3, 5-HT4, then ergots, then management of migraine, the theories for migraine, then what are the drugs for acute attack, what are the drugs for prophylaxis. Acute attack, I told you, NSAIDs, antiemetics, triptans, ergots, then CGRP antagonist and lasmiditan. Prophylaxis, 2ABC, T for TCAs, onabotulinum toxin, A for antiepileptics, GST, gabapentin, sodium valproate, topiramate. Then beta blockers, propranolol is the most commonly used. The reason why beta blockers, they decrease anxiety, they cause sedation, they decrease the triggering of migraine. Then C for candesatan, ARB, then CCBs, which are causing vasodilation and prevent the triggering of migraine. And they are not used during acute attack of migraine. Then CGRP, they all end with MABs, erenumab. Then we have galcanezumab. Then we have fremanezumab, and the last one is eptinezumab. So these are the drugs what we use for migraine. Okay, so that is about serotonin pharmacology and drugs for migraine. Thank you all.